If we're just going to keep going with our next talk here, which is the last talk before our lunch break, and we have a real treat for you here today. We have a whole team of speakers that are going to give this next talk. This is the interdisciplinary approach to early rehabilitation intervention for the stroke patient, and we have Mr. Phillip Doucette from speech therapy, Ms. Rebecca Brockson from physical therapy, Ms. Shannon Biko from nursing, and Ms. Katie Madden from occupational therapy, all here at Christiana Care.
So welcome, everybody. We have a ton of information to cover, so hopefully we'll move pretty quickly. On behalf of Shannon, Rebecca, and Katie, we're really, really pleased to be here. So what we're going to cover today is a review of recent research that substantiates early interdisciplinary rehabilitation, review the scope of practice of each of our respective groups, specifically the nurse, speech, language, and occupational, and then talk about application of that into a real-world case study. So interdisciplinary collaboration equals interprofessional collaboration. This is a term that's moving beyond buzzword status and is becoming more and more common, particularly in the medical field. And there are organizations that are working really hard to put more thought behind how to do this effectively. One is the IPEC, or the Interprofessional Education Collaborative. This is a group that first met in 2009 and featured 6 different schools of medical professionals, but has since been updated into 2016 and has become embraced much more widely in the medical field. And basically what they're tasked with is training young professionals who are coming out of graduate schools or their training curricula to basically have a better understanding of how they fit into a large team. The way that they've done this is they've organized their thoughts around 4 core competencies. So the first competency that we talk about is creating a climate of mutual respect and shared values. So can someone give me an example of something that we might think would be a shared value among everybody taking care of a patient? Anyone? Okay. What else? Short-term, long-term goals, management of pain. Okay. Anything else? Get the person better, right? Put the patient first, right? So that idea of reminding ourselves that we are all part of the same team and we are all in this together and that everybody has something that they can contribute. We can't do it all on our own. Competency number 2, use a knowledge of one's own role and those of other professions to appropriately assess and address the needs of the patient or the population we serve. So often I feel like in the real world this boils down to just trying to stay in your own lane. But you know, it's more than that. It's know your stuff, know your limits. But it also requires you knowing a little bit more about what the other members of the team are doing. So I won't do a poll this time, but think about the last time you went to a resource to learn more about, say, what another specialty did. This is something we tend to not do. We're too busy taking care of the patient sometimes to really think about that. One of the things that I think that we are hesitant to do is to just stop and ask what we think might be the dumb question, because we don't want to come off as seeming uninformed. But, you know, like professors told us back in school, there's no such thing as a dumb question. And ultimately, the more you understand about what your collaborators do, the better understanding you have of the tools of care that you ultimately need to give the patient what they need. Competency 3 involves communicating effectively. This is, again, something that I think in our time-sensitive approach to care, we sometimes don't take that moment to consider who we're talking to. we're very good about talking to patients and keeping in mind their level of alertness, their medical status, maybe the emotional capacity of the families when we're talking to them. But sometimes we assume that everyone knows the same acronyms that we know, when this isn't the case. And so if we can kind of take a step back and try to speak as simply and as directly as we can, we're not only casting off some of that language that can sometimes be a little off-putting to other professionals or make them go, oh, I don't understand that, and then they tune out. But it makes them part of the team, and again, puts the emphasis back on what's the problem that we're trying to solve. Finally, competency 4 is this idea of staying committed to the concept of a team dynamic. Now, this is something that we could have be an entire topic unto itself. So I'm going to leave that to your respective teams and supervisors to think about ways that you can start thinking about yourself less about being someone who's on an island and working on their own, but think about how do I fit into this team and how are there ways that I can continue to encourage that. So at this point, I'm going to turn things over to Becky Brockson, who's going to talk about some of the research that has been published that backs up why these big ideas can be so effective.
Hello. Okay, so I am going to be talking a little about some research articles with stroke first. And so there's actually a large amount of published literature on the topic of interdisciplinary stroke care. The research validating this approach is strongly supportive, and the American Heart Association actually provides very clear recommendations urging this approach to stroke care. Within the time limits of this talk, I'm going to talk about 2 articles, and then I'm going to go over a little bit about what the actual AHA guidelines are in regards to stroke care with interdisciplinary care. In 2007, the Cochrane Library, they published a meta-analysis of randomized controlled trials on stroke units, and they found one unit in Norway was outstanding in their results. This study, Not All Stroke Units Are the Same, was published in an attempt to qualify what the patterns were and the differences between the successful unit and then a regular unit, which was in Australia. I don't know why they picked Norway and then Australia. They're pretty far apart. So this study included 95 patients, half in the Norway program, half in the Australian unit. And as you can see, the patients on the unit with the mobilization protocols, I guess maybe I should be over here. I hope you can hear me. With the mobilization protocols, they spent more time out of bed, and the Norway unit spent more of their day with the patient. The 23%, that equals about 5.5 hours versus the 14%, translating to about 3 hours, 20 minutes, which actually means that the Norway unit nurses spent 2 more hours of their day with the patient versus the usual care unit. Finally, in the Norway unit, the nurses and the therapist, they worked together for about an hour a day versus in the Australian unit, that 0.3% translates to about 4 minutes a day of the therapists and the nurses working together. And then of note, the Norway unit, they had better staffing ratios. Each nurse had 3 patients in Norway versus in Australia, each nurse had 4 patients. So the researchers from the prior study next wanted to try to figure out what made the difference between the 2 units. Was an interdisciplinary approach part of the key? For this project, the researchers conducted interviews of staff and they audited data. And what did they find? They found that the biggest difference was on the more successful unit, the nurses were more strongly involved in the decision-making and the planning for patient care. They expressed more confidence in the various aspects of providing care, including rehab. The nurse and the therapist were both involved the first time a patient got out of bed, and they often worked together to shower or wash a patient and to help them walk. On the Norway unit, often new nurses would shadow a physical therapist for a day. The Australian nurses, they noted that their lack of training in patient handling was a barrier for mobilizing their patients. And then on the more successful unit, the nurses were taught to perform basic swallow assessments, and they felt the patients were started on a diet safely. So the bottom line was that the greater integration and sharing of knowledge, skills, and roles on the protocol team, the Norway unit, which was more successful, was instrumental in improving the patient outcomes. So then we're going to go on and we'll talk about the AHA guidelines. So this is a guideline from 2010, and it was 51 pages, so that's kind of long, but they did provide a synopsis of 10 things to know with stroke patients, but I synopsized that into 5 things. And so there's over 800,000 strokes that occur in the United States each year, and more than 500,000 people over 20 years old have had strokes. Stroke rehab requires the skills of an interdisciplinary team where nurses play a central role in the care coordination throughout the continuum. It's imperative to educate and support family caregivers. Family support is the most important environmental factor for stroke. And there's strong evidence that organized interdisciplinary stroke care and rehab initiated at the patient's time of admission and sustained across the continuum significantly reduces the likelihood of death and disability within the first year after a stroke. And finally, post-stroke care is complex, which we all know. Recently, 2016, the AHA republished some guidelines. This time they made it longer. They made it 76 pages. And again, they emphasize that organized stroke care reduces deaths and improves recovery and outcome measures. And then one of the things they changed was that they still recommend that patients receive early mobilization, but they recommend that it's applied at a sensible intensity and that high-dose activity in an early stroke is not recommended. This guideline was changed as a result of a study called AVERT, A-V-E-R-T, and I'm going to talk about that quickly in the PT part of the lecture. But for this part, the difference between what they were recommending as far as mobilization was, and what the study showed was 30 minutes of out-of-bed activity in a day is bad. 10 minutes is what they found to be safe on the study. So now Shannon Biko is going to discuss the role of the RN in interdisciplinary stroke care.